Morning. Morning, everybody. Good morning, Rahul. Good to see you there. Thank you for tuning in. So welcome back. Back off holiday, and it seems like ages ago now. Got back Tuesday, late Tuesday, and then been moving house since. So it's you might see my eye twitch over the course of this session. Morning, Steph. Morning. Yeah, it's that's the thing. It's part of the Monday morning ritual, isn't it? Right, we've got the last bit of the foot and ankle to do. We're going to have a look at the nerve and the blood supply. Hopefully, crack all that in one session. See how we get on, and then that's it. All done. Then just doing that with my ear. I forgot. I was carrying this box out of the van yesterday, massive thing, and it slid, and I turned my head to avoid it, and it smacked my ear, and it really actually quite hurt. I'd forgotten about that until I touched my ear then. Nerve and blood supply today. And then we're done. So if you've not watched this before, or you've just started watching for the first time, or the first few sessions, then basically what we do is we go through every kind of layer of the anatomy for all the different regions. So at the moment we're at the end of the foot. So we did the bones and the joints, then we did the connective tissue, so the ligaments, the capsule, that kind of thing. Then we had a look at the compartments, because obviously it's a little bit different for the foot and ankle to some other parts of the body. And then we started to put in the muscles into those compartments and where the tendons go. And now finally we're on the nerve supply and the blood supply to those regions. So having known where the compartments are and where the muscles are, it should hopefully make the nerves and the blood supply a bit more straightforward, because some of the names are named after the bones and the joints and some of the muscles. So hopefully that kind of layering on of the anatomy is useful for you, and makes it easier to revise. Good morning, Tris, and good morning, Mo. Nice to see you all back in again. Here we go. Here's autumn, ready to go for autumn. And then, so after this session today, we'll then be starting afresh on a new region. We're going to have a look at the knee, and we'll do exactly the same again. So we'll start off with the bones and the joints, and then we'll add on the connective tissue. So with the knee, it'll be the capsule, the meniscus, the ligaments, all those kind of things. And thrown in the mix as well is some clinical stuff. So I think knowing the anatomy really helps you know why you do certain clinical tests the way you do, but also why some of them aren't very specific. So if you have a look at a lot of the structures that we're trying to isolate and test when we do clinical testing, when you see the anatomy of the region, it's pretty obvious that you can't isolate a lot of the anatomy. So it's it makes that make sense too, hopefully, and makes it so that it's okay for it to be a bit grey. I think certainly when I first learned clinical testing, it was, if you do this test, it means they've torn their supraspinatus or whatever it is. And obviously we know that that's not the case. We can't be that specific. So it's useful, I think, when you delve a little bit deeper into things. So for this, the title of this one is Why Your Feet Go Numb. And it's a question that we do on the diploma course in the UK. So we do a movement therapy diploma, which is a 3-year course. And part of that, we do clinical reasoning sessions. And one of the things that often comes up in some of the case studies we discuss is why someone's foot's gone numb. Or it might be foot, or it might be feet. And so today, hopefully, it will kind of sow the seeds of some questions that you need to ask about exactly where, how it happens, what it feels like, where it's happening, and then using your knowledge of anatomy, being able to then track that back to its potential source, or maybe something that they did. Sometimes it's not anything they did. Sometimes it's a disease process, and it's just happened over time. But either way, it kind of like puts in additional information for us to use to help us come up with further questioning, and then potentially referring people or doing different tests, whatever it is. So that's the plan for today, especially the nerves and the blood supply. I think that's an important one. Right. Morning, David. Good to see you back. Best time of Monday, exactly. And good morning, Penny. How you doing? Did the move go well? It's still going. I'm in a makeshift room at the moment. Yeah, managed to get internet last week. Tested it, so it was all okay. And fingers crossed, we don't have any dropouts today. So yeah, it's all good. It's one of those where do you remember? Well, those of you old enough to remember in the UK, again, if you're not from the UK, then you won't get this reference, so apologies. But there used to be a really bad 80s sitcom drama thing called Crossroads, where the set was really wobbly. So if someone lean against a wall and it would start to wobble, and that's what it kind of feels like at the moment in here. I've got makeshift stuff set up, and hopefully next week my permanent studio will be set up. So yeah. I know that feeling. Yeah. Well, when I was younger, sorry, just to go off on a tangent. Well, my father was in the RAF, so we moved about 20 times by the time I was 16, and literally would just get a box for your room, fill it, and then off to the new place. And then the new box would arrive in your room, you'd unpack it, and then you'd be in your new room, and that was it. It's a little bit more difficult when you've been in a house for 20 odd years. It's a little bit harder. Yeah, you've got it, Penny. Yeah. Right. So let's get you going then. These are the nerves. Let's get rid of that. Yeah, so we're going to have a look at the nerves. So we're starting off with the foot, then we go knee, and then we go hip and lower back. So what we're going to do is we're going to track this nerve from its end, or these nerves from their ends back to the source. Yeah, so that's the plan. That's where we're heading. So at the moment we're looking at the nerves at the end of the body, obviously in this case the foot, and we've got two main types of nerves. And if you've done any of my nervous system sessions before, neuroanatomy stuff, then you'll realize that there's a motor component to the nerve and there's a sensory component to the nerve. And this is really important, especially for clinical testing, because we can kind of we can get information based on symptoms. Sometimes it's not useful. But it will certainly start the cogs whirring in your head, if there's a motor problem or a sensory problem. And some of them are innocuous, some of them are horrendous. So it's knowing what's what and then what to look out for. Those are the key things. But knowing where the nerves go and where the blood supply goes is really key. So what usually happens when you compress a nerve, it depends on the extent of the compression as to what then happens with the symptoms. So if you, for example, let's say, so one of the nerves we're going to have a look at today is, it used to be called the perineal nerve, but now we're going to call it the fibular nerve, because we've started to transition from perineal muscles into fibularis muscles. So there are two different parts of that nerve, and you don't need to know about it yet, just need to know that it's very superficial and it's quite close to a bone on the side of your knee. Now, depending on how tall you are and how tall the cars are, you quite often will bump this in a car park, walking through, trying to weave through the cars, and then you dunk, and then you bang the bone. And wrapping around that bone is a nerve that supplies the skin to the outside of your leg. So the lower leg, which was what we've been looking at. So that knock on the nerve will cause an insult to the nerve and disrupt the messages going down that nerve. So then you get an odd sensation around that area of your leg. And another example is if you're sitting in a somewhere where you might be compressing the nerve, so maybe like pushing it against a wall or something like that. And if you release the pressure, then the neurons can fire again, and then it feels okay. Yeah, so it's very, very transient in that respect. If there's something constantly compressing it, like swelling or a tumor, some kind of disease process or serious injury, then that will constantly be pushing on that nerve, and it will disrupt the blood supply to it. And then eventually that blood supply won't be able to get to the nerve, and the nerve will start to die. And when it gets to that point, it's irreversible. Yeah, so it won't get any better. But if it's a dink or a slight compression, you know, we had a conversation the other day with I had one with a patient where we thought that their shoes or a boots might be causing compression of one of these nerves, which is then making the foot feel funny. So let's try a different pair of shoes while they're doing the activity and see if that makes any difference. And if it's a slight compression, you release that pressure, it should come back usually within minutes. Okay, not straight away, because it takes a bit of time. Usually, sometimes it's instant. It depends on the amount of compression. So it usually takes a bit of time if you're compressing a nerve for it to come back. Now, if it's a blood supply issue and you're compressing the artery that's supplying that region, then again, if it's constant and for a long time, then the tissue isn't getting any blood, so it will start to necrose, it will start to die, and you'll also get a numb foot or numb feeling in a certain area. Now, usually with a nerve, because the nerve supplies a specific patch or a specific group of muscles, it will affect just that patch. With a blood supply, because the supply is supplying a bigger area, it usually knocks out a lot bigger region, okay, like several regions of nerves. So when you're asking questions about why is my foot gone numb, is it certain patches? How long is it for? Does it come back? If you release the pressure, does it come back immediately, which it usually does with a blood supply issue? So an example of this, not in the foot, but let's say you lie on your arm and then your hand goes numb. And then as soon as you come off your arm and you give it a shake, it comes back again, because that's a blood supply problem. Yeah. And using the hand as an example, if I have an issue with the ulnar nerve, then it's going to knock out these two fingers. But if I have a problem with the blood supply, it's going to be a whole hand issue, because the blood supply obviously supplies the whole hand. And it's similar to the foot. So if it's a blood supply issue, it will usually be the whole foot. If it's a nerve issue, then it will usually be a patch. Okay, so that's kind of bit of a background around this, and then hopefully that will make a bit more sense. So this is one of the nerves. It's from the sciatic nerve, which most people have heard about. And sorry, my watch is going nuts. I'm a Liverpool fan, and we've just signed Alexander Isak. And apologies if there's any Newcastle fans out there. But yeah, my watch is just ping, ping, ping. So yeah, sciatic nerve is two nerves. It's not just one nerve. It's two coming down all the way from the nerve roots. So they're wrapped together in connective tissue, and then there's a wrapping around each individual nerve. And then those nerves are then bundled together, and there's a wrapping around those as well. Now, those nerves can split into their separate pathways, and they can split really high. So they can split around in the pelvis, and we'll talk about that when we get to that region. In the textbooks, what you'll see is a split behind the knee. And again, that's quite common. That's the most common area for it to go, but it can split a lot higher. So you can have two nerves running down the back of your thigh, and but basically, like, for want of a word, two sciatic nerves. So those two coming down will then veer off into different directions and then go to different parts of the foot. So the first one we're going to have a look at is this one. So the sciatic nerve splits into the common fibula, okay, which used to be called the common peroneal, and the tibial nerve, and this is usually by the knee. Okay, so those are the two nerves that come down: the common fibula, and then the tibial nerve. So those are the two that join together as the sciatic nerve and then split. So the first one we're going to have a look at is the pathway of the common fibula, and that's this one just here. Now, what happens is, as it comes down as one, so this common, see on this picture, it's called common peroneal. It's going to take a while to update books, I think, pictures on the internet. So this is your common fibula, and then it splits into two separate nerves again. So this one's splitting again, and this splits by the knee. So we've got this branch here that takes a bit of a dive. This one's superficial. Then this one here takes a bit of a dive. So this is the cutaneous branch for this region here. Okay, so that's the sensory part of that nerve. So you've got a little offshoot that supplies the skin around this area here. Okay, and that's quite superficial, just there. Yeah, and that bit just there. And then as we come down here, look, this is where we've got another split. So we've got, this is the deep fibular nerve, or deep peroneal in this case, and we'll have a look at where these go in a second. So, and that is right by the fibular head. All right, so this is the top part of the fibula, right by the knee, on the outside of the knee. And then this branch here, this is your superficial fibula, and this one, by the name of it, stays near the skin, travels down the fibula, and then supplies the top part and the side part of your foot. So this is why we need to ask, where is your foot numb? Yeah, and because if you have a knock around here, around that fibular head, so this was the car bumper that we were talking about before. So if it's just at the right height, dunk, catches that nerve, because it's quite superficial. It's a insult to that nerve, which then disrupts the flow of neurons, and then it can cause weird sensations around this area here. And it's because you're not getting the usual sensory feedback through that part. Yeah, it's been interrupted. So you will feel symptoms around this area here. So see on the front of the foot, it splits. Yeah, and that's important for later, because there's another bit of the nerve that supplies that specific part there in between the big toe and the second toe. Yeah, so this is where it can get a bit confusing. So this bit is cutaneous, so that's sensory. This bit is cutaneous, so that's sensory, so that's going to the skin. And then these bits here, these are motor, and these are going to your muscles. So if we have a look at the muscles they're going to, fibularis longus, peroneus longus, old school, peroneus brevis, fibularis brevis, right? So all of those muscles that we've been looking at over the last few weeks, this is the motor supply for those. So that's where it goes. So if you have a large enough insult to this area here, it can also knock out those everters of your foot. So it will knock out the fibularis longus and brevis. So again, hopefully this starts to make a bit of sense. So if you test the strength of those, they might test weak compared to the other side if there's been quite a big bang. Okay, this is also really useful if you're doing manual therapy, because if you're treating someone's fibula head and you're doing some quite high pressure manual therapy around that area, you can press on that nerve and you can affect negatively affect the sensation and the motor input to that region. Okay, it'll basically knock out the muscles because you're pushing so hard that it will affect the nerve, and it's really superficial around that area there. Okay, so you've got to be quite careful if they're getting any kind of weird sensation, tingling, numbness, that kind of thing. If you're treating around that area, then you need to back off, especially if you're doing deeper pressure. You need to back that off. So yeah, that's that part of it. So that's the mainly we can see the superficial part there. Okay, and then if we go on to the next bit, this is where it splits here. So there's a little section there. Let me just move me out of the way. So the common fibula coming down as one, and then it goes laterally, so it moves to the outside, wraps around this fibula head. The superficial branch will travel down the fibula and then onto the top of the foot, and then the deep branch moves medially and dives into like the front part of your shin. All right, so around this area here. So if we have a look where the deep perineal goes, or the deep fibula, it's going towards tibialis anterior, extensor digitorum longus, extensor hallucis. So that's all of the muscles in that compartment there. Yeah, so that again, this is why it's useful to understand those compartments. So we've got this anterior compartment, this lateral compartment just here, and that's where the nerves go. They go and supply those compartments. So it kind of all ties in, makes sense. So you've got this kind of wrapping bundle of nerves, of muscles, all that connective tissue keeping things separate in their segments, and then they've got their own nerve supply. So if there's an issue in this case with the deep fibular nerve, then they are going to struggle dorsiflexing their ankle, because you're going to knock out tibialis anterior, extensor digitorum, so you won't be able to lift your toes, and extensor hallucis, you won't be able to lift your big toe. Yeah, that hopefully makes sense. So the common fibula splits into two near the fibular head. We've got the deep and the superficial fibular nerves. Okay, so let's have a look at that in a bit more detail, and then we'll have a look at some videos. So we've got the common fibula coming down here. Then we've got this like little pathway that the nerve goes through. And if you can remember, I told you to remember this a few weeks ago. This is the fibular tunnel. So that number 2 there. Number 3 there is the fibularis longus muscle. So that's that one there. So that's attaching onto the outside of your fibula. And then number 4, this is your superficial fibular nerve. So that's going down the outside of the leg. And then this one will then dive deep into that compartment. Number 5, the deep fibular nerve. All right. So hopefully that all makes sense. Let's have a look at some of these. So we'll go superficial first. Let's have a look at this one. Sorry, Carol, I missed you there. Good to see you here. Okay, so here we go. Let's just pause that there. So there's a lot going on here. I've tried to label everything up so you can get an idea of where everything is. So again, this is called the perineal nerve on this video because it's an old video. So we've got the common perineal. There's your patella up there. Fibular head is just underneath that massive fatty tissue. There's your fibular tunnel just through there. Extensor digitorum just there. So that's the kind of orientation of where we're at. So drop foot may have been an issue at the dorsal root ganglion or the fibular head. Yes, could be. Yeah, it could be either. It depends on the kind of compression that you get around that area and whether it fits in with the history. Yeah, so sometimes it can be something simple. Sometimes it's something in the lower back. Okay, yeah, that's good. Okay, so let's have a look at this. So there it goes. There's the superficial. There's the deep. There's the superficial just there. So common perineal there, or common fibula. So we're looking at the outside of the leg here. So that this here is the superficial branches. You can see they're on top of the muscles. They're literally just underneath the skin. And then the muscles that are supplied, fibularis longus and your fibularis brevis, just there. And then the sensory distribution is this. So the dorsum of the foot, so the top part of the foot, and then the side of the shin. Okay, so all that kind of area there. Cool. So that's the superficial bit, and then the deep part is this one. So we'll follow that and have a look at that one. Here we go. So through the fibular tunnel. And then there it is popping through there. So this is going really deep now into the front of the leg. So there it is buried within those muscles. There's your tibialis anterior, so it supplies that. And then it's running all the way down. And then it will come through the kind of retinacular at the front. So we're looking at this area here that it's supplying, yeah. So all that anterior compartment. So tibialis anterior, tertius, if you have a tertius. And then that bit there, the web space between the first and second toe, that's the sensory part of the deep fibular nerve. Okay, so that kind of fills in the gap of the sensation. Just going to pause that there. So all of this is superficial. This bit here specifically is the deep fibula, and then up here it's a mixture of the two because of the cutaneous branch that comes off. Yeah, so if you remember, if we go back there, so that little branch there that came off, yeah, that is coming off the common. Yeah, so before it splits. So that's why it's fed by that bit. So that area there is that purple patch. This one here is the blue patch, and then the big in between the big toe and the second toe, that's your deep fibular nerve, and that's the last patch it covers. So like I was saying, if it's not your whole foot either, so it's not underneath the foot, it's not the sides of the foot, the inside of the foot, it's just that patch. There will be variations in it, okay, so it might be slightly drifted over more one side than the other, but it's a different sensation. So if we go back to the hands again, like instead of those two fingers, it's the whole hand, yeah, and that's exactly the same kind of thing with this. If it's blood supply, it will usually be the whole foot. If it's a nerve compression, then it will be certain parts of the foot, maybe the top of the foot or whatever as we go through. Cool. So that's your fibula. You just scoot through there, and then we're onto the tibial. So the tibial is the other one when it splits, usually above the knee. Yeah. So we've got the fibula and the tibial. So this is I was just reviewing this this morning. What a cracking picture of a foot that is. That's kind of my level drawing. That there's no detail to that area at all, but you can get it. You can understand what it's trying to get at. So here's the sciatic nerve just here, and you can see there's a ring around it because usually it's the two nerves wrapped together. Then we've got this branch coming off, which is your common fibula. Okay, which then splits, as we've just seen. And then the other branch coming down to the back of the knee. So this is looking at the back. And it's in that space at the back. We haven't done the knee yet, but you might have heard of it. It's called the popliteal fossa. So it's the back dip, basically, behind your knee. And that's that. This is where your tibial nerve will go. And again, this is another one of those areas where it's quite unprotected. It's fairly deep. These structures are quite deep. You'd have to push in like ridiculously hard to compress them. But the gastroc muscles, so the calf muscles, will come up and split, and they'll come up onto the femur. and then the hamstrings will come down and split and go either tibia or onto the fibula head. So we have like this diamond shape at the back of the knee, and within that diamond, that's where your tibial nerve will be, and your blood supply as well will be in that space too. So that's this region here. So it is fairly vulnerable, but it's obviously quite deep. But if you're getting in there with an elbow, doing some treatments on the say the hamstrings or the top of the calves, you don't really want to be pushing around that area there. Again, you could affect the nerve and just irritate the structures. Okay, so it's it's not worth messing around that region there. Same if you do acupuncture, that kind of thing. Yeah, so why would you do that around that region? There's nothing there apart from the neurovascular bundle. Yeah, so you've got the nerves and the blood supply. So as the tibial nerve is coming down, we've then got branches coming off, and again we've got sensory branches, and we've got motor branches going to the muscles. So we can see the muscles that we've got supplying here, so gastroc, soleus, tib post, flexor digitorum longus, flexor digitorum brevis, flexor hallucis longus, flexor digitorum longus, and then it goes down into the foot, and this is where the foot sensation comes from. And if you have a look at this is now going medially, mainly, but then there's also this little branch coming off going laterally as well. So we've got the whole undersurface of the foot covered by the tibial nerve. Okay, so let's have a look at that. This is one to make you aware of. When the tibial nerve comes down, it splits off into loads of different little branches, and one of them, this one here, is the Baxter's nerve, and it's coming down and coming over this area here, and this is the inside of the heel, just where people complain of plantar fasciopathy. So sometimes there can be a compression of this Baxter's nerve, which is presenting with a loss of sensation on the inside of the calcaneus, so the inside of the heel bone, and that can be mistaken for a plantar fascia issue. All right, so it's on there. There's quite a few people that mention it, especially in podiatry. So it's definitely something that gets confused. So it's worth knowing about. Okay, so the FBLPN, which is what the Baxter's nerve is. If you have a look here, it's the first branch of the lateral plantar nerve. All right, so we've got this. It's a splitting of the plantar nerve, and there's different branches. Okay, so this one here goes to the inside of the calcaneus, and around this area here, you've got muscles like tibialis posterior, especially tibialis posterior, where and because of the retinacular around that area, if there's any kind of injury to that muscle or any kind of expansion of the muscle at all, so if it's irritated and swollen, that kind of thing, it can compress Baxter's nerve and give you weird sensation. Or if you're wearing quite tight shoes, because it's quite superficial. And again, I had a patient in with it was a cyclist, and he was getting numb foot, and it was only when he was about 15 miles into a ride, and did all of the tested, we couldn't reproduce his symptoms. It was only when he was riding. So I've got a bike in the clinic, so we got him on the bike 15 minutes before his appointment, and he was on the bike getting going, brought his symptoms on, and then we could test it. And what we assumed was happening was that as he was getting hot and sweaty and his foot was starting to swell a little bit in his shoe was the structure of the shoe was compressing the nerve. So we basically got him to change his cycling shoes, and then he was fine, no problem at all. Okay, so sometimes it can be something as simple as that. There's no issue with their back. There's no problems with the a disc or anything like that. It was literally compression at that point. Yeah, yeah, that's very confusing. Yeah, well, hopefully you'll see here. Let me just pop that on there. Yeah, confusing, call it lateral plantar nerve, but it's on the medial foot. Yeah, this is the reason why. So if we have a look here, so this is the medial aspect, and there's the medial branch. Yeah, there's the lateral branch, and they're both coming from the same place. So they wrap underneath and then go off into their different directions. So if I just move me out the way, so the lateral plantar nerve, that one there, that will go across and supply this area of the undersurface of the foot, that area just there. Okay. And then as we come into the medial plantar, that one there, so again, this is the undersurface of the foot, so big toe, second toe, third toe, into the bit, the fourth toe. See how the structure is very similar to the hand. Yeah, it's like the median nerve and the ulnar nerve around this area. So and then this supplies the undersurface of the foot, but on the medial aspect. So even though it starts medially, it goes laterally, and that's why it's called the lateral plantar. Yeah, but that was a good observation. Yeah. Baxter's nerve. Is there anything we can do to differentiate between the nerve being affected to it being plantar fasciopathy? It's usually, if it is a plantar fascia issue, it's usually worse in the morning when they take their first step. It usually eases off as they exercise and move, so it gets easier rather than worse. And you can do something called a tinal tap. So where the nerve comes down, you can just tap the nerve, and if it's sensitized, then often it will reproduce the symptoms around that area. But you won't get that with plantar fascia. Yeah, so plantar fasciopathy. The tinal tap shouldn't make a difference to that. It could be a bit of both, just to make it even worse. One of the things that I have used, which has been very useful, is and people poo-poo it, but it's been really quite good, quite remarkable actually, is cupping. Yeah, so a negative pressure over those superficial nerves. So if you imagine it's all kind of squashed and compressed, if you can provide a bit of negative pressure, get the foot moving, trying to mobilize those nerves, trying to ease a little bit of the compression on it, and that has been really good in relieving some symptoms. Yeah, so that decompression effect can be quite useful in that respect. Cool. And then the last bits to kind of fill in the bits, the gaps, if you like. These are purely cutaneous nerves. We've got the sural and saphenous nerves. And the sural nerve will come down the back here. So a branch off the tibial and all the way down the back, and then come down to the back of the heel. Okay, so around that area there. And then the saphenous, this is a bit of a weird one because this comes from higher up. This comes from your femoral nerve and is a cutaneous branch of the femoral nerve. We haven't covered that yet, but we'll do that when we get to the hip and into the knee a bit as well. So we've got this whole area here and on the inside of the calf. Yeah, so all the stuff we've done so far have been lateral, been on the outside, or on the top of the foot or undersurface of the foot. This fills in the gap on the inside, and it comes from your femoral nerve, L2, L4, and this is the saphenous nerve. So it's coming all the way down until the inside of the foot, which you can't see on that one. Yeah. We've got some branches of the sural nerve which fill in the gaps for the lateral part of the foot as well, but main part of the sural nerve coming down to the back of the heel. So that kind of fills in all of the skin maps of that whole region. Okay, so these are quite superficial, these nerves. So saphenous medially, sural coming down laterally, somewhat laterally with one of the splits, and then posteriorly, and then medially we've got that branch of the tibial coming around into the plantar nerves, and then on the top of the foot you've got the superficial and the deep fibula. Okay, easy, eh? It's a nice one to get my head working after coming back from holiday. I've just realised the time, and yeah, I think we're pretty much done for today. So what I'll do is we'll do a bit of a recap next week with the nerve supply. So just a quick kind of 5 minutes, and then done. Then we'll have a look at the blood supply for the area as well, and then we'll move on to the bones and the joints of the knee. Okay, cool. Thank you for tuning in. Good to see you guys again. Thank you for the questions and the comments. I really appreciate that. Making it a bit more interactive. That's really good. And yeah, I will see you next Monday at 10 o'clock. See you then.